we're honored to have him, that he's come over to Spokane, and we're pleased that he will conclude our day with his thoughts. And I want to give him a please warm welcome of applause to have him join us.
Well, thank you very much. No hoots over there, no hoots. It's great to be here. I just reflecting on it, I had to go give a talk in the middle part of the day across the river, and realized my first time here was, I hate to say it, 45 years ago. I came to Spokane, and it was a different town. I remember they called it Cougar Country, and it was actually a football game, and I came to play. And I'll say that we won and the Cougars didn't, just to let you know, but it was a very good event. Listen, I want to talk to you a little bit about, not a little bit, I want to talk to you about what we're doing, where we're going with healthcare reform. It's really a pleasure. It's interesting coming and listening all day to the different things. You hear the struggles that everybody's having, the problems, the issues that are coming up, and I just have to tell you, this is my second time through the same job. I don't know if you know that, but 25 years ago, I had the exact same job, the same office, same view, and I'm getting better at it. And the good thing about having had the same job twice is, one, you see a lot of the same issues, but you also have a little more humility about what you can do personally and what you need to do with your partners. And you are the partners that we all need. And while we have the same problems, we have a different world right now. And the different world isn't because of, just because of the ACA, but I think it's what the ACA actually, well, I'll say it is because of the ACA, because what the ACA means and what it can do with us, what we can do with it. But one of the things I worked on for the last 8 years has been trying to figure out how we communicate. I was doing a lot of communications work, how we communicate about the issues around healthcare to the American public. And we started off by asking the question, we've been trying to change our healthcare system for the past 40 or 70 years, whatever the right number is, and we've always failed. And what do we need to do differently? And part of that is we need to really understand what people want and meet their needs and talk to them about ways that they really care about. And they really don't care about the details that I talk about all the time. They don't care about all these, back in the day it was the pay or play versus the mandate versus the this versus that. What they really care about is whether they and their family get the care they need, and that their kids have a better future than they had, that they can look forward to some security as they change jobs from place to place. And so while we like to think about all the details, and I'll talk about some of them, I think we have to really go back all the time to that touchstone of why we're doing it and who we're really serving. And that's really the people of the state, and make sure we address those issues that they care about, and that we should measure everything we do by whether we make their lives better. Also, I think that while we have a lot of problems, and you hear in the conversations, there's this problem and that problem, we have this, and they're all real, that as we solve each individual problem, we really don't solve very much. We had the same problems I mentioned 25 years ago. We have solved them, each of them, many times, or at least addressed them, and we still have the same problems. That's because I believe that we haven't made some, I'll call, what's the right word, systemic, big changes. We haven't really turned the boat. The boat needs to turn. And if you've ever driven a ship, which I have actually, a freighter, that when you turn the wheel, the ship doesn't turn. And it's a very worrisome thing when you're doing that. And about a minute later, or not really a minute, maybe it's only 10 seconds or 20 seconds, but then you start seeing the bow come around. And I think we're driving a huge freighter right now, and we have to make sure we know where we're going. We have to start turning the ship. And up to this time, we've been going back and forth like this and making no changes of significance in the long run. Now, we have made a ton of good changes. I'll say, since I was in the governor's office last time, we have a lot of very good things going on, a lot of activities, a lot of improvements. But they haven't changed some of the fundamental things, and those fundamental things are access, costs, and people having the security of knowing that they're going to have health care for their family. And so we really need to keep our eye on the ball, make sure we do what needs to be done. But my hypothesis, and I think it's correct, is that the ACA gives us great opportunity. I know everybody said that already, so I'm not going to try to repeat it, but I'll tell you why I think it is. And that is that as a society, we do some things. We make changes. Up to this time, I think we've been very confused about where we're going. Are we a competitive model? Are we a regulated model? Are we different things? And I think the ACA helped us decide on certain things, actually decided for us if you want to know that. But there's a social agreement that we're going in a certain way. And we're going to do things and there are certain parameters. They're not all the tiny details of the 2,000 pages, whatever it is, but it's really the general themes. And I want to hit those themes because I think they underlie all the things that we have to move ahead with. First off, much as people don't talk about it, the fundamental principle in the ACA is personal responsibility. It's a very controversial topic with some people. Some people love it. But if you look at it, the two things that people believe in personal responsibility is that people pay money for what they get, and secondly, that they take care of their health. The ACA does that. Everybody going into the exchange will pay something, as much as they can afford. And I think you look at a lot of this, it is dependent on and we have huge expansions of prevention that I think are first steps. We could do a lot more, but those are important things, and people can actually start getting some of the barriers out of the way, and hopefully being able to care for their own health. And that is what people define as personal responsibility. Believe it or not, when you ask them about a high deductible plan, they do not equate that with personal responsibility. In fact, they hate it. The second thing is we need to we decide we're going to change some of our pricing stuff. Pardon me. Let me go. We decide we're going to change our insurance practices. Insurance practices have, as Uwe Reinhardt says, the devil makes them do it. I don't think any insurance executive wants to exclude sick people, doesn't want to charge older people more because if they can't afford it. But because of the competitive pressures, the way the market is structured, that's the choice they have to make. One of the good principles in the ACA is that we decided to change those practices and we limit those opportunities for I'll call contrary or not very productive policies. Those include pre-existing conditions, but also including certain services. As people probably know, the individual market here did not have pharmacy benefits or obstetrics. It's very hard if you're a pregnant woman and not able to get individual insurance if you're going to get pregnant. So it is some crazy things we do, and I think we've resolved some of those. I did mention changing pricing, and that really is focusing on we're not really going to punish the frail or the elderly. We have in this time through pre-existing conditions, but also pricing policies done that. And now there's some more limits around that, and that's an important thing. I think the one statement that people have not heard much about is the prevention built into the ACA. If you read it, it really is one of the substantial changes that we have, the prevention fund, but also on the personal side, as everybody knows, we have huge increases in personal prevention, mammograms, all the colonoscopies, but all the different prevention things that are proven to be effective by the I'm going to block my name on it, but anyway, on the Preventive Task Force. And I think that's really an important thing. We have not made that commitment before. We've done little pieces in Medicare. Some insurance has done more than others, but we finally said it's important to do. But that's personal prevention. But I think to make people healthier, personal prevention is helpful. I think communities need to be helped as well, in the sense of getting barriers out of the way so people can be healthy. Also, we made a decision that everybody in the country should have access to affordable care. Obviously, not everybody's going to get in for a number of reasons, but everybody who is a documented immigrant or a citizen will be eligible to get into get affordable care. Now, people can debate the affordability issue with certain groups, but I'll tell you it's a lot better in the future than it is now. As in everything, we hope to improve things. You want to make things better, and we need to fix things. But that's a huge statement that we're doing that. The last couple more things. In the area of controlling costs, we actually made a huge statement there, I think, and that was that we're not going to use global budgets or a single-payer system. Now, there's a lot of debate about what the right choice is, but we made a decision to use a competitive model. But with a competitive model comes a number of things. And that one of those things is we need to have data or transparency of information, if you know what a competitive system is. We need to have we have to have the multiple payers, we have to have competition where we actually have apples to apples comparison. And the exchange is a beginning point. There was a comment by somebody in one of the groups that it doesn't include all the plans now, the inside and outside plans, and I agree that it doesn't do that. But it does give a lot more choice and information and comparability. I was on the Public Employees Benefits Board 25 years ago, and we had 12 plans or something like that, and I could never figure out, and this is, I was supposed to be smart in this area, but I could never figure out what was a better plan. Because, is it because of the eye, benefit or this? They vary things around in such a complex way that I could never value one over the other, saying there are better plans other than I like the brand or it was my own doctor. And people mainly make that decision. Hopefully with the comparability of apples to apples, you can use the things you care about. In other words, quality measures, whether it's the right doctor, the right place, the right brand, whatever it may be, you can use those and know that you have comparable plans underneath that in fact, you don't have to know all the details of. We also need in a competitive system to make sure that there are certain pieces that are in it and not out of it. By that I mean we've talked about integrating, I think I'll talk a little bit more about that, but about the SIM grant, the State Innovation Model. Certain things like mental health and substance abuse have been outside of a lot of the health realm, yet it is very impactful upon healthcare. It causes a huge increase in costs and other things. We know that there are other functional things such as team approach to high-risk people makes a difference in how you care for them. There are a number of pieces like that are in there that will fall out if we don't have a way to embed them into a competitive system. So we are, I think we made that decision. And it's actually really helpful to have made those kinds of decisions because then we can say, well, how are we going to reapproach this? How are we going to approach both the competitive side, the pricing issues, I'll say the good behavior by insurance companies and having the right strategies for competition, and make sure everybody's in. So where does the governor want to go given all that? Interesting thing is I actually had a conversation about an hour and a half with him last night about this exact issue. What does he care about? And you probably know he didn't run on health care. He commented about he supports health, the ACA. But what he really wants to do is to make the state a better place for both workers, businesses. He calls it working in Washington. And part of that is making efficiencies in certain things. In other words, we have transportation, we have to make sure it works well. We have, the government has to be done efficiently. We have the lean management. And in healthcare, we have to make sure it's affordable for businesses, for employees. We have to make sure people are healthy, that they get the care they need so the workforce is ready to go. And this is an important issue for him. So the first thing he wants to do is really take full advantage of the ACA. As you know, he's put his full strength and office behind getting this thing implemented. We have 6 agencies working on it. You've heard a lot of it today, from the exchange, the insurance commissioner, DSHS, Healthcare Authority, OFM. I'm sure there's another one there someplace I'm missing. Anyway, we have a lot of agencies that are engaged in it, and to their credit, they're working very well together. I get to chair that group, and we had our meetings this morning, in fact, looking at how we are doing with getting the exchange up, which I'll report is doing very well, and we had a couple concerns. that are now look like they're resolved. Those had to do with interfaces with the federal government in the computer area. Everything else is gearing up in a good way. But we're taking full advantage of that, as well as the Medicaid expansion. And obviously the Medicaid expansion is, well, you know, actually if we'd done the Medicaid expansion only, it would have been the biggest change in healthcare almost since I got involved in health policy. So that's a really good thing. So his high priority is it's done right. He just wants us to make sure there's no problems, it works, and we get the benefit of it. Interestingly, he's also very focused on improving the health of the people in our community. Mary, we're very happy to know that he has actually prioritized prevention higher than almost everything else. And you're welcome. I didn't have to twist his arm. That was his idea. But the point is, you know, that if we're going to have a healthy community, we have to start at the community level. We have to do personal prevention, and we need to have a good place to live. And our next generation, as you probably know, is destined to be less healthy than their parents for the first time in the history of America. And I think that's a bad legacy to leave behind. And he is dedicated to doing something about that, which I give him a lot of credit for. His story is we were talking about parks about a week ago, and he wants every kid to be able to go to the park, sleep go to a good state park, be able to sleep and hike in the mud. But he also wants them to be healthy and be able to hike, which is an important thing. So it was really very good that he wanted to do that. But given all that, you know, we have a lot of work to do in front of us right now. And actually, on the system issues is what we've been talking about mostly here today. It won't be you, I mean, it won't be me, it'll be you, and it'll be you and I and everybody else around here having to make some changes or some improvements in what we're doing. And it isn't going to be a one-time change. This is going to be, since we have been trying it for a long time and watching the arc of our changes, it takes a while to change systems. Somebody said it takes 17 years to change the behavior of an individual. I don't think it's quite that long, but after watching my fellow physicians, and maybe it's true, I'm not sure. We change very slowly as a profession. So we need to start really working on these things directly. We need to keep costs down. We have to bend that cost curve. There's no way that the healthcare changes we've made are sustainable unless we can keep our inflation rate where it is now, which, you know, for 3 years has been very good at about 3.9%. We need to do that off into the future. We can't go back to the 7, 8, 9% inflation, and we've never been successful at that. The only times we've been successful is when the public sector is looking at the private sector and saying, I'm going to regulate you, or I'm going to do something to you, and then the inflation rate comes down. I don't think we're going to be able to wag the finger very long, so we need to put a lot of other things in place to make sure that's sustainable. But I think, and may be wrong, but I think that if we run at 7% inflation, go back to that a lot of things we care about are going to unravel, including our institutions. So, what we are doing, you've heard a little about you've heard a lot about the exchange and what's going on there. I talked about the prevention, the community transformation grant that is a backbone of a lot of the prevention stuff we're doing, as well as getting kids healthier. But one of the big pieces is the SIM grant, or the State Innovation Model. And as I look forward, going forward, I see that as being the place where all this stuff has to come together. I see that as a blueprint for the future. I think something that there's a lot of input from a lot of groups. Whatever it comes out with will be a place to start. It won't be the last word on everything, but I think it sets a stage for us to move ahead. And I kind of hold to the idea of collective impact, which you probably all know about, but the idea that we agree on outcomes, we hold ourselves collectively or as a group responsible for the outcomes, and that we actually use our money, funds, and treasure to move towards those outcomes, which means we need to have agreed to outcomes about where we're going. And I think right now we're close. I don't think we're there. I have a feeling that we're not going to have a big statewide process. We're going to probably have maybe it'd be a legislative process, maybe something else, but make sure we all agree on what those outcome measures or outcome goals are, and then make sure we have measures for them. But we're going to have to be measured. We're going to have to make sure we go where we say we're going to go. And we need to hold all parts of the healthcare system accountable. That's all the way from the purchasers through the providers. The purchasers themselves have a unique role, though, and we are, through the governors, met with some business leaders around the state on this. What we would like, though it's not set at this time, we would like an agreement amongst all the major purchasers on a set of goals of where we're going, and see if we can have those driven through the system coming similarly from different purchasing places. So we're looking at that and see if we can do that. That may be a way to do it. As I mentioned, the data and information, we actually have a grant in. We should know by the end of the month whether we get it, which will be to start developing a all-payer database, which will build on the work that's been done. The insurance commissioner, as well as the Puget Sound Health Alliance, the insurance commissioner is taking the lead on that. We're working with them. If we do get the grant, we'll embed it into OFM. Only to run the grant. The actual database would be external to the government, would be in the Puget Sound Health Alliance. We think that's really important. We are living in a world where we buy things and don't know the price. And when we met with the Washington Roundtable people, interestingly, the biggest issue they brought up was, how do we, I cannot run a business if I don't know what I'm paying for different products. If I don't have the data and what I have, knowing what I spend my money on, there's no way I can make business decisions. And I think that's true for everybody. We get a rolled up price, we have no idea what we're getting, and whether we're paying it 75% or 25%. So it's important. I mentioned the purchaser agreement, and I think we're moving that direction. We know there are some needed system changes that are out there, and that's built into this grant. We're looking at a lot of things and getting a lot of input. We know that we talk about the behavioral health integration, coordinating with the social factors. One of the things that we always talk about how much impact healthcare has on our health. But whatever number you use, it's between 16 and 6. It's a very small percentage of the health impact by just the healthcare system alone. I actually think there's a bigger part, and that is the social equity part of it. Because if low-income people get health care, it removes stress. And even though the health care may not make a difference, they live a better life. However, we have to look at other things besides that, and we need to really make sure those are wrapped in. And that means, what about housing? What about other social supports? How do we make sure that there's an access to those things that make a difference in both people returning for hospital readmission, or all the way to whether somebody has a stable enough life that they can take their medicine, care for their diabetes, do what has to be done. So we're looking at that. We also need to really improve our workforce. I don't mean improve the quality, but we need to have the right numbers in the right places. And I've worked a lot in rural healthcare in my interim between last time and this time. And I've visited many rural communities, and there's no doubt that the workforce issues there are very real. Getting people to live and work there is hard. The numbers of people are less. Oftentimes, the economy of the community is completely dependent on whether you have an institution there or not, and whether you have doctors and an institution. And if you don't have an institution, you don't have doctors, usually. So we have to figure that out. We have to figure out how we make those changes appropriately. One of the real, I'll say, soft landing things we have to think about is that every study that's looked at actual cost savings and has realized those cost savings have come out of unneeded hospitalization, which means the hospitals. And so if we're going to be shifting what we do, we have to figure out what hospitals become and how they change. And I know they're thinking about it every day, but there will be a change, and there'll be a different confirmation of services that are going to be available. So, the other thing in our work is that everybody we talk to not everybody, but most people, is that people are beyond pilots. I mean, people are tired of doing pilots, but people want to start making changes. And I think we're really focused on that as well. We may not start something statewide. First of all, let's talk about our levers. The state has only certain levers. We're a purchaser of healthcare. We can drive things through our own purchasing. We can do some regulatory things, but they aren't as effective, except for maybe some of the data stuff and setting the stage, and I'll say managing the competition so we make sure it's a fair market out there. And that would be done in conjunction with our legislators and the public. So we don't have control over that. We do have some control over what's in our contracts within the bounds of the legislative parameters. So we do have a few things, but it's not going to be, we can't drive and change the whole system ourselves. The state can help set the stage, have the debate, I'll say immortalize some of the agreements we make as a community. But going forward, we need to have everybody on the same sheet with the same goals, going the same way, or we're not going to be successful. But we need to start waving it in. We need to start putting things in place through community by community. We need to make sure that those things work, and we need to continually improve them. You know, we know from IHI and other things that doing continual improvement makes a huge difference, which means we have to keep looking at what we're, implement things, test them, improve them, implement, test, improve, and we need to do that throughout the healthcare system. And nobody has an answer to everything, so we have to have that humility as well. So, that all said, I'll just say it again, everybody's talked about the opportunity. I personally came back into government this time because there is an opportunity to make a real difference now. The governor's dedicated, so that gives me more hope. Talking to legislative leaders, they all would like it. Some are more skeptical than others, but I think everybody wants a system that works better. And I've not met a person yet who's been happy with our current system entirely. Some people are satisfied with their insurance, but everybody sees the flaws in it. Some see them bigger than others, but I think I've always worked with the people who don't have a lot of options. I've always worked with low-income people, and they certainly tell me day in and day out that the system isn't as good as it should be. Our numbers reflect that. We have not such good outcome measures that we need to really improve. And I think right now we actually have this tipping point, this ACA that says, okay, we're going to do it. This is the way we're going to do it within the parameters we laid out. But it's really up to us to really make sure we take that opportunity. So I appreciate the good work and good thoughts. I think we all have our concerns and worries about whether our institution is going to get funded or our clinic or whatever it may be. But we have to think bigger than that. We can't just say, okay, as long as my hospital, my clinic is taken care of, we're okay. We're all going to lose in that battle. We'll be back here in another 10 years. Prices will be out of hand. We're going to be struggling even harder than we are now. And I assure you that given the politics of this particular issue, if we aren't successful in our lifetime, we're not going to see a big improvement. It will be either cataclysmic or just degenerative. And I think either of those are bad ideas. So that's kind of a down note. So I want to put an upper note, guys. A lot of people have gone before us, done good work. We need to carry that forward, and Mary Selecki here will have all the answers for you later on, and will answer your questions. But thank you all very much. I look forward to working with you, and so does the governor. Thank you.
Good questions?
I'm interested when healthcare reform will take into account public health prevention activities, incorporate those.
Well, that's interesting you should say that. One of our things that we're working on, and Jack has been working with us, but there are a number of other groups as well around the state, the Department of Health, is looking at where are those places where we can integrate it. We can bring prevention into the fold, at least integrate it with, if not included in, what we do is what we call medical care. And medical care can be defined as what we pay for with premium, or it may be broader than that. But if we did find it that way, maybe we know that including certain things may be good and may be very effective. We know that getting housing, for instance, we're not going to pay for housing out of the premium, but making sure people are hooked into that. Knowing that we get the barriers out of the way. By that I mean, if kids can't walk to school or can't walk, if the walk score in their home is 0, they don't walk. And we have to think about how we improve that walk score for all the kids. We have to make sure when they do go to school that they get good food. All those things are things that we're at, and I think I mentioned the governor last night actually brought that to the top of our pile. as far as things he wants us to focus on. So we're going to be working on that. I'm not sure exactly the form. I have some ideas, but we're going to move ahead with that as an issue. And I think everybody talks, I mean, let's be frank about prevention. Everybody's talked about it forever. We did the Public Health Improvement Plan back in 92. Well, we passed it in 93, right? And everybody said, great, it's a good idea. And we go say, oh, let's get some funding to help the local health departments do something. And it turns out that 80% of the people love prevention. Half of those people say it's a community responsibility, let's go ahead. That's only 40% when you add it up. The other half says it's a personal responsibility. And we have to move prevention, so we expand that community responsibility across 50%, or you're never going to have public support. I can tell you how to do it because I studied that in one of my interims, but there is a way to do that. But we have to start making that a part of our healthcare system if we're really going to improve health in the long run. I agree with you. The governor's elevated, and we're going to be working on it. We look forward to help from all you folks to move that along. Yes?
I've heard a number of people today talk about obesity as a epidemic and something that we need to address as a health and a prevention issue. But I have a friend who said that I have her permission to use her as a case study. Mm-hmm. She's overweight. She's definitely overweight. She knows that. But she's more than overweight. And it's contributing to some health problems right now. And she's had to quit work because of one of those health problems. The only way she could get help from any program or Medicaid for her health problem is if she was going to be disabled for a year, whereas the reason she wanted help for her health problem was so she could go back to work. Mm. We have a disconnect between the ACA and all this push for seeing obesity as a personal responsibility healthcare issue, yet under the ADA, it's a disability. Mm-hmm. Mm-hmm. And until we address that fact that we are really totally schizophrenic about how we are going to approach obesity, I don't think we're going to solve that problem. And in her case, she has a chaotic life, and I'm walking with her to try and help her fix this, but it's not easy. There's no program that's going to fix it for her.
Well, let me be very clear. The ACA doesn't say that obesity is the person's only personal responsibility. In fact, if you look at it, I think it's more of a community responsibility. We have set up our diet, what's available, the expense, that we've subsidized certain fatty, sugary foods to a large extent. And I think we have a community responsibility to take that on. Obviously everybody is responsible for their own health. We can't change her behavior. She can change her behavior, but behavior isn't the only thing. It has to do with whether she has opportunity to do things. And hopefully for her, which we know with obesity, that once you are obese, it's very hard to change. We have to prevent obesity, and I don't think go around blaming people. Now, go to Medicaid. Medicaid does cover, you're talking about different sorts of interventions. They do cover that. You do not have to be disabled for a year. You do have to follow a regimen and go through a process. I actually took care of a lot of people on Medicaid who did get surgery, in fact, even for obesity. But you do have to do certain things. There are certain criteria which measure success. But I wouldn't blame the Medicaid nor ACA. Medicaid didn't cover that before, but they now have a way of doing that. You go ahead. You have another question for me.
It's not a matter of blaming Medicaid. It's just that that's a very sticky problem.
Oh, absolutely.
And, but it's very easy to say that we need to address obesity. But you look around this room, and this is not a typical cross-section, and we're probably the wrong people to be having that discussion.
Well, I agree with you. It's a tough problem, but I think not addressing it, working on it as a community is a mistake for us. And also it's a mistake for the health system. It's just on a pure cost basis. We're going to have too much diabetes now and in the future. So I just think it's a smart thing for us to do. Any other questions? Okay. So thank you all very much. Happy to talk to you. Contact me anytime. Happy to talk to anybody about any good ideas. Okay. Thank you.
That concludes our day. Thank you so much for your time, your attention, your mental energy, your physical energy, And we hope that you will continue to engage us through stateofreform.com, through our email, 5 Things We're Watching, through our book, through our job board, through all the other things we're doing, and we hope that you will be with us this time next year. Thanks.